Hello, good afternoon, everyone. Thank you for your patience. We're just waiting for to get as many people signed up. We will start shortly.
So good afternoon, good morning, or good evening, colleagues from wherever you may be joining us. Thank you for joining for this third webinar in a series that we have hosted over the past few weeks around strengthening nurturing care in humanitarian response. So I hope that many of you joining now are returning for the third episode, but if this is your first webinar, you're very welcome to join too. A number of participants are still joining, but we will move ahead given the time and availability of our speakers. I'd be grateful, as housekeeping indicates, that if you can keep your audio and video disabled, only speakers will be showing themselves and be audible at any one time. Please feel free to use the Q&A function at any point. We will have a Q&A session after all the presentations. Unless anybody really objects, we will record this session so that you can follow up afterwards and indeed share with other colleagues who are unable to meet today. And we will be sharing both the recording and the presentation afterwards on the Global Health Cluster website. So firstly, I would like to remind everybody why we're doing this webinar series. And that's really to remind ourselves, as if we already know, humanitarian actors are very able to provide lifelong services and interventions to meet young children's holistic needs and improve health outcomes for young children affected by humanitarian crises. And a particular process and framework for shaping that response action is the Nurturing Care framework. Past studies have shown that perhaps not everyone is so familiar with the framework itself, or indeed how to apply this in ongoing response. So what we're doing through these webinar series is to update people on the value of the framework, its key facets, and provide examples of how it is already being applied. And that was done in the last two webinars. In this third webinar, we'll look specifically about how we can integrate or institutionalize nurturing care within particularly the health cluster response and what that means for health clusters and their current and ongoing collaboration with other sectors and clusters. So we will be inviting a number of speakers. I'm very happy to say that we have 4 speakers with us today. We'll move through all the presentations, and then after the presentations are finished, we'll have an opportunity for Q&A. So who I'd like to invite first, and someone you may have seen already in previous webinars, is Dr. Aisha Kadir. Aisha is a pediatrician and senior humanitarian advisor for Save the Children International. She works in both clinical care, public health research, health policy and advocacy, and her clinical work is in emergency pediatric medicine and social pediatrics in Europe and in humanitarian settings. So Aisha is going to give us a brief refresher of webinar 1 to help frame the discussion as we go through today. So Aisha, welcome, and over to you. You have, I think, let me check, you have 10 minutes. Thanks.
Thank you, Linda, and welcome everyone. So I would try and keep this brief. I'm not sure if it's possible to go back because I have animation. Yeah, there we go, just one. There we are, perfect. So just to briefly recap on webinar 1, it was a 2-part webinar that we were focused on the science behind the early child development and why this is important and actually life-saving in humanitarian health responses. And so you can see this graphic on the left of the screen This is from our very first speaker, James Cairns from the Harvard Center on the Developing Child. And you can see here, there's this figure in the middle, and there's stressors coming up from the outside, and you have all the different organ systems. It's describing exactly how they're harmed or how they're changed when there are significant stress. So when this starts to harm the body, we call it toxic stress. And it has to do with a fight or flight response. And it has a huge impact on how the organ systems function, but actually in young children, especially sort of from the period before birth up to 3 years of age, they are undergoing the most rapid brain development and also significant organ system development, where they're setting a foundation for how their body is formed. This actually can alter the architecture of a brain, like literally the physical structure of the brain. So learning how to cope with adversity is a really critical part of healthy development of the body and the mind. And short-lived stress responses the body can cope with, but when it's chronic or when there are multiple, then it becomes toxic. And so if you just advance one click, you can see the kinds of the core fundamental things that we need to do to be able to support and protect children. And at the very top, you see the supportive, responsive adult-child relationships. And so when we talk about responsive caregiving, we're talking about parents and caregivers who are able to sort of recognize what's happening with the child, how they are acting or reacting, and then respond appropriately to promote healthy, positive adaptation and healthy, positive development. Even this is important in the absence of a crisis, but it's especially important in crisis contexts. And then at the bottom right, you'll see strengthening adaptive skills in context. So this is for children and for their caregivers, helping them to adapt positively and to have tools to learn about things they can do to adapt positively in the specific context of what they're experiencing. And then the bottom left of that is reduce sources of significant stress. And that we do in all of our different sectors. We're trying to meet the basic needs of people in crisis contexts. But all of these are the core structure of how we can protect children's health and promote a normal, healthy development. And if you advance the slide, the second part of the first webinar was actually very specifically focused on the Nurturing Care framework, which is an approach to promoting and protecting early child development. And at the bottom left of the screen, you'll see there is a thematic brief. There's a hyperlink there. I strongly encourage anyone who hasn't seen this to go to it and read more thoroughly about it. But the Nurturing Care framework is this, you see, we call it a sort of a flower with 5 core petals. This is effectively, what nurturing care means is it means ensuring a stable environment that is sensitive to children's health and nutritional needs, with protection from threats, opportunities for early learning, and interactions that are responsive and emotionally supportive and developmentally stimulating. So there are these 5 interrelated, indivisible components. And if you click forward, the first one we start with today, good health, and click forward again, adequate nutrition, safety and security, opportunities for early learning, and responsive caregiving. And so this is essentially the structure of the Nurturing Care framework. And you can tell by these different components that this very specifically is targeting the social determinants of children's health. The important thing to remember, and what we'll talk a little bit more about going forward, is how this actually impacts children's health and why it's an acute health need. So next slide, please. So in the second webinar, we moved from the science to what is actually happening. And we had 5 examples of programs in action where programs or teams are doing early child development work in different sectors. And I think you'll hear me start to use the word integrated and the word contextualize a lot in the next few slides. But starting with Myanmar, we learned about the developmental milestone assessment tool. It's a simple community-based approach that basically is shifting some primary care nutrition services into the community to reduce overcrowding. And the way they were able to incorporate early child development assessment and basically support for caregivers to promote and stimulate healthy development was through coordination. And there was a collective understanding from different partners from different sectors about what we mean by comprehensive service delivery, and early child development was part of that. And then there was also a collective understanding of what the minimum standards should be. And so they were integrating their work with social protection and social and behavioral change to basically optimize their resources and access to services. And then click next. In Syria, we learned about a child-friendly center. This is a health center where early child development was integrated into the core activities that were already being delivered, so existing services and interventions. And they did basically what they integrated assessment and counseling for child development at every child visit. And they also had a community-based component, and they had a really high success rate, both for knowledge acquisition of the caregivers, but also health workers. And the take-home point from this, and I think the most profound actually learning from this for me as a health professional, was that the health actors, where it can be looked at as, oh, this is another thing we want somebody to do in a health response. And the health actors might get annoyed and say, well, you're asking me to do even more work. That wasn't their response. Their response was, we wish we knew about this when our children were young. So it's integrating early child development is something I think health workers will fundamentally get behind. They recognize that it's important, but they don't necessarily have the tools or the knowledge. And if we make this a routine part of health services for children, which it is in high-income, non-crisis settings, then it can work. And next, we learned about Colombia, where they were integrating early child development services into nutrition interventions. And these were a range of interventions: static facilities, mobile health services, and also itinerant spaces. And then the next example we have is from Ethiopia, early child development as well as maternal mental health services. These are integrated child development and mental health services that were done in just under 100 primary healthcare facilities in Ethiopia, which is an emergency context and post-conflict. And they were doing developmental monitoring, counseling, play therapy, as well as mental health services for the mothers. And this was part of all their key maternal and child health and nutrition services. And lastly, we learned about how UNICEF in Afghanistan is taking an intersectoral approach to nutrition, child development, and well-being at scale, particularly in child-friendly spaces and nutrition interventions. So on the next slide, we have some nurturing care framework recommendations. These are taken from the thematic brief that I have the link for at the bottom of the page, and that's been put in the chat kindly by Maria Benavides. One of the key recommendations is that we need to integrate and to our services, and they need to be crisis sensitive. And this is across health and nutrition, education, sanitation, child protection, and others, but especially these key sectors. And the focus should be children and family, and then figuring out, identifying how we can align our national policies. And so these services should be a mix of interventions that are adapted to context, and building on these contextually appropriate practices, we need to integrate them into existing service platforms. So we don't want to make a new service. This is not about a new early child development service. What it is, it's about including early child development in every health activity we do, whether it's in the outpatient department or in the emergency department, or an ANC or PNC, or a well baby clinic, immunization services, IMNCI, labor and delivery. Anywhere a child is found, or a pregnant woman who's expecting a child is found, or a parent is found, then we should be including early child development activities in one way, shape, or form that's relevant to the context. And in order to do this, we know that this is not well understood in humanitarian contexts. So we need to assess the capacities and knowledge of our frontline workers from the community through to all cadres of health workers, and then build their capacity to fill the gaps in line with national policies. And next slide. Another key recommendation is that we should be sustaining specific actions that contribute to nurturing care in a way that's relevant for the setting. So this is contextualizing and also what's relevant for the phase of the emergency as well. So this can be a range of things: continuing access to basic services, which we already try to do. So community and home-based services, these should continue throughout the emergency, but we should integrate support for responsive caregiving and early child development into the health services whenever a child or parent is found, and make these services child-friendly. When we talk about child-friendly, this isn't just painting a Mickey Mouse on the wall. This is actually really protective for children, because it makes the health services less scary, number one, which means it's being in a place where they're afraid and where they're unwell and where they might be, have blood tests or something that is like painful, or they're already in pain. This is already a stress. And so if we can reduce the stress, that actually can improve their outcomes. But more importantly, or more than that, beyond that, making the services child-friendly, it's been shown to, like, this is also about having health providers who understand how to care for children. And so play therapy is actually a technique that we use for health services, particularly in nutrition services and humanitarian settings. We have good evidence to show that it shortens the length of stay and improves the nutrition outcomes. It improves healing. It's been shown time and again across different contexts. Safe play and learning spaces in all intervention and support spaces should be available. We should minimize or prevent separation wherever possible, and reduce the stress levels of caregivers and children, and ensure that vulnerable populations are targeted, and that the spaces and materials and structures and whatever we're doing for our intervention is accessible to children and families with disability. My last slide is really the take-home message. The Nurturing Care Framework is an approach to promote early child development and the social and environmental factors that are affecting children's health needs. And so it's very relevant for an emergency. It's also relevant for more stable settings. However, incorporating early child development into health responses in the acute phase of an emergency is life-saving. It will save a child's life a week from now, a month from now, and most definitely years from now. So this is really a key part and parcel aspect of health services for children, informed health services for children. So our next step now is to really figure out how do we do this. So I'll hand back over to you, Linda, to take this discussion forward. Thank you.
Many thanks, Aisha. Very good summary of what we've already been looking at over the last two webinars, and the key principles and approaches that we need to further accelerate and institutionalize in our work moving forward. So just to take another example of applying NCD in different contexts, I'm going to invite Dr. Amir Yapavar to join us. Amir has over 17 years of professional experience in advising, managing, and coordinating health, nutrition, and early child development programs in both humanitarian and development contexts across a number of regions globally. He currently manages the nutrition and early childhood portfolio of UNICEF's Lebanon office, and at the same time, he's also double hatting as the National Nutrition Sector Coordinator in Lebanon, where I'm sure he is coming across the health sector in his day-to-day work. So Amir, I'm going to hand over to you. You're going to give us an update on the RISE initiative, which you have been absolutely fundamental in being the founder of, and you're going to describe to us how this RISE approach is promoting nutrition and early childhood development in Lebanon. You have 10 minutes. Over to you. Amir, we can't hear you, so can you just check your You're not on mute. Okay, we seem to be having a few connection problems with Amir. So
Yes, can you
we
hear
can
me
hear
well?
you now. Yeah, yeah. If it's easier
Okay.
without your camera, then please go ahead.
Yeah, if I may need to turn off my camera because I think the bandwidth is not very
That's
supportive.
okay.
So, good afternoon, good morning, colleagues. My name is Amir. As my colleague explained, I'm managing nutrition child development portfolio for UNICEF in Lebanon, but also double hatting the nutrition sector cluster.
Okay, Amir, we seem to be having sound problems again. We currently can't hear you. Okay, what I would suggest while Amir checks his connection and perhaps finds an alternate.
I think we've lost him, Linda. He might have
Yeah.
dropped off.
Okay, so no problem. We know connections aren't great and there's a lot going on in Lebanon right now. So Ron, if it's okay with you, would you be willing to come in a bit early? Great. So I would very much like to introduce Ron Powells, who's a child protection and child rights professional with over 25 years experience in humanitarian development context. Ron is currently the coordinator for the Global Child Protection Area of Responsibility within the International Humanitarian Coordination Mechanism. He's worked in a number of countries, both in Ethiopia, Kenya, Tanzania, Zimbabwe, and also China, where he was leading the child protection component of integrated early childhood development within both the education and health sectors. So, Ron, the floor is yours to share your perspectives on how further institutionalizing of the nurturing care framework can be done in humanitarian health interventions. Over to you, and you have 10 minutes. Thanks.
Thank you, Linda, and thank you for having me today in this webinar on institutionalizing nurturing care in humanitarian health interventions. Good morning, good afternoon, good evening to all of you on this special day, because we're actually celebrating the anniversary of the adoption of the Convention on the Rights of the Child, which is the most widely ratified human rights convention in the world. The CRC also covers civil, political rights, as well as economic, social and cultural rights. And it's a document with interrelated rights. And this interrelatedness of rights is also critical in early childhood development and the nurturing care approach. This interrelatedness is also captured, and please the next slide, in those two quotes that I've taken from the first webinar, which also shows the crucial connections between child protection and health. Because what we do in child protection, I will go into that a bit more detailed later, is supporting families with young children, which will then build a strong foundation for lifelong health, but also provides prevention of any health consequences of some issues that children are dealing with in emergencies. And then secondly, also the holistic approach of nurturing care is requiring this cross-sectoral collaboration. Next slide, please. As we all know, prevention and response to child protection risks is critical in the early years, both for the children's brain development and the caregiver attachment formation that is taking place during this time. And humanitarian crises are clearly an adverse childhood experience, with children at greater risk of abuse, neglect, violence, and exploitation, as well as toxic stress due to separation from parents and caregivers, and grave violations such as sexual exploitation, killing and maiming, attacks on schools and hospitals, child labor, and others. And they exacerbate pre-existing child protection risks. This makes it paramount that interventions are sensitive to young children's specific protection needs. And early childhood development links to child protection in a few main ways. Firstly, in terms of ensuring children's safety and security, and promoting responsive caregiving, as outlined in the Nurturing Care framework. And also in terms of the resilience to child protection risks that is built within children when all dimensions of the framework are promoted. As mentioned in the previous slides, ECD requires multi-sectoral interventions. And I would like to add coordinated multi-sectoral interventions. Next slide, please. Next slide. Yeah. Although we may not always label it as ECD, as child protection practitioners, we do have a number of interventions as child protection actors at the onset of an emergency that could be categorized as early childhood development or contributing to early childhood development. At the onset of a crisis, these range from psychological first aid or basic emotional or psychological support for caregiver mental health, to minimizing violence and stress, to preventing separation of children from their parents or caregivers, and reducing caregiver stress. Next slide, please. And during protracted crisis, child protection actors provide psychosocial support for caregivers, support families experiencing high levels of stress. We contribute to alleviating family conflicts, create opportunities for children to play and learn, such as in child-friendly spaces. And we encourage positive and responsive interactions between caregivers and children, including through parenting programs, and reduce caregiver stress. Next slide, please. In the work that we do in emergencies, we are guided by our child protection minimum standards, which were revised in 2019. These standards cover the areas I mentioned in the earlier slides and include several references to early childhood, such as in Standard 10 on mental health and psychosocial distress, which mentions that these mental health and psychosocial support programs must be provided and tailored to children at all ages and stages of development. With early childhood, support for children's rapidly developing brains and their positive attachment to caregivers. Standard 15 on group activities for child well-being mentioned the necessity to provide separate spaces and time slot and tailored activities for children aged 0 to 2 years with their primary caregivers and 3 to 5 years. Work with early childhood development and other sector staff with specialized knowledge to implement group activities for children in this age range. And where possible, engage children's parents and caregivers to strengthen children's attachments. We also provide developmentally appropriate play materials to promote children's development and psychosocial well-being and brain function. Standard 16 on strengthening family and caregiving environments includes activities related to positive parenting, while Standard 23 on education and child protection looks at joint interventions for children ages 0 to 5. That includes and that are based on sector specialties, promote early childhood development, and address the particular concerns of this age group. And then finally, Standard 25 on working with nutrition colleagues is to facilitate discussions on early childhood development and child protection in mother-to-child nutrition activities. Next slide, please. Moreover, the child protection minimum standards, they also include standard of working with the health sector, Standard 24, which, by the way, as a coincidence, Article 24 of the CRC is about child's right to health as well. So Standard 24 talks about the health and child protection programming playing critical and related roles in ensuring the safety and well-being of children in humanitarian action. Supporting children's health increases children's protective factors, while supporting children's protection can and should improve children's physical health and well-being. So it shows this important connection, this symbiosis between child protection and health, and how important it is that we actually contribute to both each other's outcomes. An integrated approach to health and child protection is one that is safe, protective, inclusive, systematic, complementary, valid for all sectors, and participatory for children, families, and communities. Among the key actions are, for example, looking at common areas of concern to health and child protection, which could, for example, be early childhood development, include interventions that address the links between health and child protection throughout all phases of the program cycle, as well as the development cycle, I would say. Document the impacts of health interventions on children's safety and well-being, and child protection interventions on children's health. And work with child protection actors in multi-sectoral coordination systems for mental health and psychosocial support, as well as case management. Next slide, please. The Early Childhood Development and Child Protection Emergencies technical note that was drafted by Plan International and UNICEF also mentions here a couple of areas for collaboration between child protection and health colleagues. That is linked to, for example, when it comes to preparedness, establishing referral systems and established partnerships so that children receive psychosocial, nutrition, health, and other necessary support. Working with ECD, health, or education actors to adapt and prepare monitoring tools. Working with ECD, health, or education actors to adapt a parenting manual that is culturally relevant, where child protection staff can add value with sessions on child protection, abuse, exploitation, neglect, positive discipline, deinstitutionalization, and birth registration. In the response, it's important that we work together on running parental programs, as well as supporting parent groups with key child protection and health information and psychosocial support. Among these areas of response is also the work that we do in establishing and running child-friendly spaces or other community-based psychosocial support programs. Next slide. And finally, our publication working with other sectors to enhance outcomes of MHPSS elements of child protection, an introductory guide for child protection practitioners, adds a number of other areas of collaboration that are critical for the mental and psychosocial well-being of children and their caregivers. These are related to supporting interventions that promote the prevention of physical illnesses, mental health conditions, malnutrition, and substance abuse among children and adolescents. Advocating for provision of specialized service for children, adolescents, and caregivers with severe mental health disorders, where we're looking at particularly the level 4 of the MHPSS pyramids of specialized services that are required. And working together with the health sectors to ensure that psychosocial support activities provided by child protection actors are adequately linked to mental health services offered by healthcare actors. Case managers play a vital role in this. And these links are mainly created in the MHPSS Technical Working Group. Next slide. So, as child protection, we do work together with other clusters, with other sectors, particularly in emergencies and in situations where clusters are established. As we can see in here in a sample from a humanitarian response plan, that we support multi-sectoral and integrated responses that contribute to child protection outcomes by enhancing referral pathways and networks through a multi-sectoral approach. particularly by strengthening those referral pathways and coordination with child protection caseworkers and other sectors for more holistic care. So this is just to show that we do this work, working with others to achieve child protection outcomes. Although, and I looked in a couple of HRPs, there's not necessarily a direct or specific or implicit reference to ECD. We do work together on areas that's, as I mentioned earlier, could be labeled or could be contributing to early childhood development. We also saw in the second webinar examples from Colombia, which adapted services for migrant children through child-friendly spaces, nutrition support, and positive parenting. And we heard from colleagues in Afghanistan about the large-scale ECD activities that were done through UNICEF, like child-friendly spaces and nutrition support. Next slide, please. Now, there are, of course, examples of where we have worked together on ECD, and I won't go into the details of this, but you can find that also in those examples in a technical note. But just to say, they're examples from partners that we work with within the child protection area of responsibility. In Uganda, Plan International had a community-led Action for Children program that was low cost and a community-based ECD model. It focused on strengthening the child's protective environment, so the parents, community, government policy, and provided direct support for children. And it did that through parenting sessions that included key health, nutrition, and protection information for parents, positive parenting techniques, and modern psychosocial well-being and strengthening relationships within the family. The mixed method evaluation of it showed positive outcomes in children's cognitive and receptive language development. And additionally, there was an improvement in mothers' psychosocial well-being, improved relationship between mothers and fathers, and greater father support to the care and development of their children. In the Syria conflict, the International Rescue Committee established the Families Make the Difference parenting program. It included sessions that aimed to strengthen caregivers' resilience and psychosocial well-being, and to encourage positive caregiving practices. They also developed additional sessions to respond to caregivers' stress and to strengthen children's resilience in the midst of conflict and displacement. And this program was implemented in Iraq, Jordan, Lebanon, and northern Syria. And also here, the outcomes were very positive. Caregivers reported significant increases in the use of positive coping strategies. Using the child discipline module of UNICEF's multiple indicator cluster survey, significant decreases were also detected in the self-reported use of violent discipline, which is a subskill that includes psychological punishment, physical punishment, and severe physical punishment. The program also found significant decreases in the prevalence of negative feelings and increases in caregiver resilience. And therefore, probably, because of all these decreases, less referrals to the health system, including the mental health system. What I've tried to show here is the critical role child protection plays in early childhood development and in implementing a nurturing care approach. But this role is limited if we're not connected and work together with equally critical other sectors, and particularly our health colleagues. And moreover, speaking as the global coordinator for the CPAR, this working together requires coordination and some sector leading it, whether that's the education or the health sector. For example, the Early Childhood Development in Emergencies Coordinating Learning Cohort initiative by the INEE, Early Childhood INE's Early Childhood Development Working Group, the Sesame Workshop, Moving Minds Alliance, and University of Virginia's Humanitarian Collaborative, is showing us how this could potentially be done, which looks very exciting and promising. So next slide, please. Here are a couple of resources that show some of the work that we've been done and that I've been referencing in this presentation. As I said, the important thing is that we do work together to bring bigger outcomes for children in adverse situations and do that in a coordinated way. Thank you.
Many thanks, Ron. Some good examples of ongoing work and much to ponder on. Just in the interest of time, I'm going to move straight to back to Amir, who I'm happy to say has been able to rejoin us from Lebanon. So welcome back, Amir. And we will give you the floor. You have 10 minutes to update us on your work through the RISE initiative. Over to you, Amir.
Thank you very much, Linda, and colleagues. Apologies for the technical issue with the Zoom. So I will turn up my camera just to make sure that the bandwidth helps the 10 minutes of presentation. So as mentioned earlier, my name is Amir. I'm managing nutrition and child development program for UNICEF in Lebanon, but also double hatting the nutrition sector coordination in the country. And it's my pleasure to be invited to share the experience of Lebanon on this integration. As you all know, a child's brain develops quite rapidly in the first few years of life, and nutrition, together with other components of nurturing care, they play a vital role in supporting healthy brain development. So exposure to childhood well-being risk factors can leave destructive and sudden impact on the growth and development of children and generations. And definitely healthy brain development in these years is shaped by the environment of adequate services, care, and diets in which young children grow up, an environment when risks are prevented or their impacts are mitigated, and protection is promoted, and this fosters healthy early childhood development. Unfortunately, in Lebanon, young children have been exposed to accumulated nutritional and child development risk factors during the couple of years, and hence is expected not only their growth, but also the brain development is being silently affected. Indeed, the growth and developments are very interconnected, and hence such interconnected problem is in need of interconnected solutions or holistic approaches to be addressed. Our solution in Lebanon to this interconnected problem materialized as Rising Initiative to address the deteriorating nutritional and childhood development situation in the country. Next slide, please. Informed by the Nurturing Care framework, Rising utilizes multiple platforms, as are shown on the screen, to simultaneously address immediate and underlying causes of malnutrition and early childhood developmental deprivations and impairments among the most vulnerable children. So the term Rising is not an abbreviation. The significance behind the name Rising lays on the aim of the initiative, which is to prevent stunting and other forms of undernutrition, but also associated cognitive deprivations, and hence to help all children in the country to rise and reach their full growth and developmental potential. Rising Initiative relies on key essential nutrition and developmental interventions that are aiming at enhancing adequate diets, nurturing and responsive care practices, and nutrition and child development services to prevent all forms of malnutrition and developmental deprivations. So this initiative values the precious and important moments of contact with children and family. So the idea is that these precious moments are used simultaneously to promote responsive care, feeding, healthy nutrition practices, and consequently to prevent all forms of deprivations. For example, if a family and a child are rich, we will not do only screening for malnutrition, but also for the early childhood development milestones and danger signs. Or once caregivers are reached with an IYCF counseling, we also seize the opportunity to provide integrated care for child development counseling and social behavior change interventions. So the graph above is showing a number of delivery platforms that are part of the Rising Initiative, But for the sake of this webinar and the focus on the health system and health sector, I want to focus on the health system, especially the community platform that has played a pivotal role in promoting the idea of the program. At the community and outreach platforms are used as part of the Rising Initiative for an integrated package of preventive and promotive interventions, including social behavior change, screenings for both malnutrition and early childhood developmental deprivations, but also early detection and referral of malnutrition developmental deprivation. Next slide, please. So in terms of the community platform, our work on the outreach has been basically in collaboration with the health and nutrition sector, being mainly focused on enhancing the system capacity of the community health workers with development and operationalizations of a harmonized community health worker program. And our work on this is done through three main pillars. Pillar 1 focuses on landscaping the existing community health worker models in the country. Pillar 2 is developing a standardized minimum package of services and the needed guidelines to offer integrated health, nutrition, and ECD promotive and preventive care. And Pillar 3 is focusing on developing and putting in place operationalization toolkit for the CHWs, which basically hovers around how to do the promotion and prevention, which includes management and supervision of the CHWs, including accountability lines with the health system, supervision procedures, working environment, remuneration, incentive schemes, and etc. The second is on recruitment and qualification, which includes selection process, roles and responsibilities, qualification, certification. And a third and a fourth, which are more about the technical content, focuses on the tools and manuals needed for home visitation and outreach activities and networking and coordination. Next slide.
Dr. Armour, could I ask you to just slow your pace down very slightly so that the interpreters can follow your pace? Thank you.
Sure, thank you. Definitely. And next slide, please. So the whole Rising Initiative has been also coupled with a systematic education program to enhance the skill and knowledge capacity of the frontliners, either they're in primary healthcare centers or they're community health workers or staff working in the nurseries or daycare centers for children. Building on the work done with UNICEF in other offices and regions such as ICARO, the Rising ECD Education Program is developed composed of 18 modules focusing on all dimensions of nurture care framework as listed below. So far, the capacity of over 300 frontliners from mentioned platforms are enhanced in the country and are equipped with the skills and knowledge sets to offer integrated nutrition early childhood development interventions, focusing on a number of these modules. I'm just mentioning them, but it's not limited to this, on responsive and stimulating care, safeguarding and prevention of violence, responsive and optimum infant and young child feeding, nutrition practices for young children, identifying children at risk of nutritional developmental deprivations, as well as age-specific health concerns and needed referrals for those. I'm not going to read through all the titles of these 18 modules, but these are available and they will be extremely helpful materials for any country who wants to have a multi-system approach towards enhancing the skill and the knowledge capacity of the frontliners. Next slide. The program is also coupled with the standard materials and end-user information education communication tools, among which the important one that I want to refer here to is the age-specific milestone cards or checklists that are used by the frontliners to assess the developmental milestones of children and to identify children with danger signs from the development perspective, in addition to the health and nutrition danger signs, and to identify those at risk who are in need of deeper and more specialized assessment and services. So these milestone cards are age-specific and they're developed for a number of age groups, including, for example, at 2 months, 4 months of age, 6 months of age, 9 months, 12 months, 18 months, 2 years, 3 years, and 5 years. And when you go down within each of these checklists that are again available, in addition to the malnutrition and other health basic problems, the milestones and also the danger signs in terms of developmental delays are captured. Next slide. And next slide. Okay. We understood when the milestone cards were put in place that these are really pivotal elements for the health system in terms of continuity and systematic use across the board. So to institutionalize the integrated survival and thrive milestone screening, tracking and follow-up and referral, the milestone checklists are also incorporated in Ministry of Public Health's digital health management information systems called MERA, which enables a path of traceable and alert-based system for all children in catchment areas of health facilities to be monitored, assessed, and referred and followed up. So digital platforms capacity is also used to reach practitioners and parents. Using online platforms, continuous e-learning will be offered to frontline workers in different settings to enhance their skills and technical capacity on integrated nutrition and childhood development. ECD modules for parents will be also integrated in existing digital platforms of Ministry of Public Health, such as Sohatna, to reach the caregivers who are not utilizing any facility or community-based services to promote their awareness and practices on integrated nutrition and early childhood development. Next slide, please. Yes, so to ensure the whole narrative that I just explained in a few minutes is supported by robust evidence, and it's also based on fresh evidence on the ground on integrated nutrition child development status, in partnership with concerned sectors, including nutrition, health sector, and also with the support of Harvard School of Public Health and groundwork. We are currently undertaking the first ever Lebanon's integrated macronutrient, anthropometric, and child development survey. The survey will provide updated evidence on macronutrient status, including anemia, trends in stunting, wasting, underweight, and obesity, but also on early childhood development status, as well as efficacy of the salt iodization program, diets of young children, and root causes of malnutrition and developmental deprivations, as well as prevalence of risk factors related to the nutrition-based non-communicable disease, but also the risk factor related to the early childhood developmental care offered by the parents. Currently, we have completed data collection across the country through a dedicated team of over 108 surveyors. Almost 6,500 households are surveyed. Around 17,000 questionnaires are completed across the age groups of young children, adolescents, and women, including over 3,300 questionnaires and profile data for nutrition, early childhood development outcomes using both ECDI 2030, but also GZIP for the younger children at 2 years of age to be able to have a measure for the ECD outcome across all age groups under the 5. Over 7,000 anthropometric measurements are done. Around 7,000 blood samples and urine samples are collected to assess the macronutrient deficiencies, but also the salt samples across the households are collected to assess the iodization program quality, which affects not only the health, but also the cognitive development and the capacity of the nation. So we are so hopeful that by having the results of this study, we can have a more evidence-informed adjustments to our policies and programming across this integrated approach in the country. My last slide, next slide, please. My last slide is focuses on the role of the nutrition sector. Us, as the leader of nutrition sector, we have felt that the narrative of integrated early childhood development in any of the sectors has been quite orphaned. So the nurturing care framework was not really given enough attention. So the nutrition sector, in consultation with all partners, led ministries and other sectors, specifically health sector or cluster, has dedicated an outcome under the nutrition sector response strategy, focusing on nutrition early childhood development, including measurable indicators and tangible activities coupled with needed capacity development for all partners. Nutrition sector has also put in place a sector advocacy strategy to be enabled to advocate for supporting plans, projects, and programs for provision of integrated nutrition in early childhood development on the ground. This approach has helped the sector to shift a narrative from a good to do thing to a must do, from merely focusing on treatment and health interventions into an integrated nutrition, health, and ECD, from heavily health system oriented to a multi-system approach. And the upcoming evidence definitely will further help all nutrition and health sectors to inform further policy program reforms in the country. With this, I would like to pause and give the floor back to you. Thank you.
Amir, thank you so much. And again, very pleased that you could rejoin us and share your program from Lebanon. Much appreciated. What I'm going to do now, obviously, we've had 3 speakers to date who've made a very strong advocacy for the use of the nurturing care framework and how it's can be promoted in a number of settings and through different sectoral perspectives, all of whom have said the importance of having a link with the health sector. And to bring that conversation forward, I would like to invite our colleague, Dr. Pen Amma, to join the conversation. Pen is currently the Health Cluster Coordinator in Ukraine and probably a little bit sleep deprived after some noisy nights in Kyiv. Pen has over 15 years experience of leading and coordinating emergency health response operations in conflict settings, also in major disease outbreaks and settings of natural disasters. He has played leading roles with both WHO, the World Bank and health sector NGOs to support both governments themselves and health sector partners to deliver life-saving support to populations in need. Pen is a medical doctor with a master's degree both in public health and international relations, and he's particularly interested in areas of emergency response, infectious disease prevention, management, early child development, and health system reform and governance. So Pen, what we'd like you to do, you've heard many things by previous speakers, but what I'd like to do now is give you the floor to really share your own experience of engaging with the early childhood development in a number of settings where you've been operating, and maybe to frame that within the kind of context of, from that learning and from that experience, how and when do you feel it's relevant to incorporate the recommendations that are being promoted around ECD and the nurturing care framework into health cluster, health sector action, and maybe consider some of the barriers you might face in doing so and how you may overcome some of those. So over to you, and then I'll open up the discussion with other cluster colleagues online. Thanks.
Good afternoon, Linda. Good afternoon, everyone. I'm very, very delighted to be with you today and to contribute to this discussion. My name is Pen Amma. I am the Health Cluster Coordinator here in Ukraine. So just to say it, there is a popular adage that says that you can only arrive there if you know where there is. And so far, the previous speakers have been telling us where there is, and we've been listening on how to get there. So I'm just going to maybe allow me to contribute to that discussion to say how it's been working and possible relevant entry points on how to incorporate ECD, and also reflecting a little on some of the experiences which I've been facing in some of the countries which I have worked in. So so far, the Bible of the emergency response is the HRP. This humanitarian response planning is actually the output that comes from the humanitarian program cycle. And this cycle starts with a need assessment. And as an entry point, usually before the HRP is developed, the HNO, which is the Humanitarian Needs Overview, a document that just looks at the various sectors, the various clusters, and the various gaps that exist in the sector, highlighting them to inform the decision-making in terms of what would be the policy for funding. So most of the sources that information sources that I use to write this humanitarian needs overview, the MSNA, multi-sector needs assessment. You can also use GBV IMS, smart surveys, DHIS to survey information, early warning, alert and response systems, displacement tracking, just to name a few. In other sectors, you have other ones like the Education Management Information System, amongst others. So basically, as Ron had mentioned, when you review HRPs, you find very little mention of the word ECD. And this is probably for a reason, because in terms of gathering the overviews, nobody actually thought of this ECD to be able to get it really informed in the HRP. So this is usually the starting point, and really to be able to make change, this is where the leverage has to be. And the leverage also has to align with the overall overarching strategy in terms of the response. In humanitarian response, the response is driven mostly either maybe, depending on the context, conflict, sometimes malnutrition, sometimes displacement, political reasons. So in function of the way the response is carved, some overarching strategic objectives are carved and defined in the policy that way. So it makes it sometimes a little difficult and also possible to miss out what is important for the little kids which we aim at providing ECD services for. And this is where, from a cluster perspective, it's very relevant that in terms of doing the humanitarian needs overview, sources of information which are relevant, which we've mentioned, should also be scrutinized for the indicators that outline what ECD is. And it's only through this lens that you can also have a policy document that incorporates ECD satisfactorily. This is the first point. In terms of planning, in terms of strategic planning, this is where the different clusters can come in to be able to make the contribution in line with what is outlined in the Nurturing Care framework. And before I go further, I would just like to mention that the Nurturing Care framework can't be implemented solely on its own in the humanitarian sector. It needs to get anchorage from systems that existed before. So if we're looking at services like good health, adequate nutrition, safety and security, responsive caregiving, and also opportunities for early learning, we always find this in every context where we operate. So how do we galvanize, how do we draw the strengths of the existing system to be able to align interventions along services that exist to amplify and also for sustainability? So these are some of the analysis that usually at entry point, a strategic view, we can also incorporate. Unfortunately, in a humanitarian context, and depending on the country where you find yourself, you don't have maybe leadership on the ministry on the government side, depending on the sector, in terms of issues that concern ECD. I would use the example of Cameroon, maybe in 2019. I would use another example of Central African Republic in 2017. So when leadership, when government, when there are no policies that exist, sometimes it becomes difficult to be able to navigate the issues when it comes to what kind of package of intervention should maybe be retained. And the premise of humanitarian action has been not to do harm. So in terms of interventions, you also want to see how, even when interventions are implemented and the partner leaves, you kind of find some continuity. So if you're implementing ECD, you want to make sure that after you leave, there are some partners or some people who continue with the trail of activities to be able to make sure that the gains that were appropriated during the period of implementation get to stay long-term, and that many people benefit from it. So that being said about the planning process, and which obviously would need intersectoral joint planning, and also some work plans and activities that kind of align with the mandate of the nurturing field. It's through this kind of means that you can be able to push. However, there have been some challenges at national level, especially because of the mandate of humanitarian response. Humanitarian responses most of the time are deemed and defined strategically to be life-saving. So in terms of life-saving, you would have to convince whoever the power be to understand that ECD interventions, although they might in some interventions have you can observe immediate gains, in the long run get to contribute and maybe build human capital to be able to enable children and the future generations able to thrive and implement and go about the activities normally. So this will need some high-level advocacy, the humanitarian coordinator, the government leadership to be able to have this kind of people who are also playing the role. And sometimes on the side of the government, you need to be able to bring together the leadership not only sectoral, but intersectoral as well, because most of the time you find programming being vertical, but no communication at the top, maybe between the Ministry of Health, the Ministry of Education, the Ministry of Social Protection. And it becomes very difficult when we start going to operational level, where more discussions need to take place, where the proper implementation takes place. So that being said, from an ECD perspective and also in emergencies, implementation of ECD would vary context by context because of the nature, because of the way the setting is organized. So in settings where you have policies actually written, drafted with minimum packages, with what is expected at each level, you would find humanitarian action involving incorporating more ECD activities. Where you don't find this, you would find it less. And you will also find more siloed action at grassroots level if you also don't have, if you have siloed actions more at national level. So the push has been more for integration at strategic level, but also to make sure that our leaders are accountable in terms of their actions in getting policies being drafted on which we get to anchor on, but also ensuring that they are also contributing to their own part of the pie to be able to ensure that these activities go on. Because if you don't put some money into something, actually you're not promoting it from a planning perspective. So it's one of the sides that we always want to also have them contribute. However, I would continue from where the previous speaker mentioned about interventions across the different areas of the nurturing framework. A lot is being done in emergencies, but no one uses the word to say, this is ECD. And because it's not said that way, it's often misplaced. And because it's also said that way, it gets difficult to be able to show the gains. So from a cluster perspective, the objective would be to be able to come up with examples of indicators, just as outlined by the previous speaker, in terms of interventions on each of these components to be able to show, because this is the only way you get to. So in terms of the joint planning, you have to be able to come up with activities that are implemented at each of the service delivery points in an intersectoral way, and which also aim at bringing out results in terms of short-term reporting processes, but also over a period of time, 3 years, 5 years, to be able to show what gains the system has made in terms of what has been implemented. From an operational standpoint, there are several entry points, and the entry points would depend on the way the context is being made. In emergencies, we have, most of the time, you find people who are receiving services in a circumscribed, well-defined environment. When the setting permits this way, ECD activities can be easily implemented, given that you would have, I'll use the example of IDP settlements, refugee camps, where you can have more multi-sectoral projects, more partners concerting under the canopy of the camp management to coordinate activities in a more structured way to be able to deliver on the mandates of ECD. And this kind of operation, it becomes very easy to use community health workers who actually define them, to use the existing structure, be it health facilities, be it schools, be it maybe the playground that, this common child-friendly spaces or spaces where specific groups of people, maybe the elderly, the men, the women sit together to be able to go through with the different elements or the different priorities as outlined in the nurturing framework. In other contexts where you find beneficiaries in the host communities, it becomes a little difficult, and the approach has actually now to be different. And this is where the input, this is where the contribution of the system that existed before becomes very relevant. In that kind of system, you would want ECD interventions that anchor with existing systems, maybe health facility, maybe elementary school, and then you have a preschool beside, for instance. You would have to use existing healthcare workers, existing social workers who are empowered to be able to do outreach interventions based on packages that are being defined to be able to implement. You would also have to rely a lot on local leadership in terms of men, the women groups. You would also have to also align with whatever structure exists. In some settings you would find governors, but I think the most basic would be the councils and the mayors. And these are the people who could ensure a sustainability over a long period when projects and emergency response gets out. So in terms of programming on the emergency side, it's very relevant to be able to incorporate, but to take a look again and to review what is the package of services in terms of ECD offered at health facility level? What is the package of intervention of services being offered in the community by an outreach post, maybe a mobile clinic moving to a location? And when you look at the packages, this is the only way you get to define the human resources and what they should be doing based on indicators that are outlined from the outset. So, however, the implementation of this would mean that you also need to be able to have some means of information reporting and information gathering that gets to reflect the bigger objectives in terms of the bigger results in terms of processes, because in emergency response over a very short period, you want to see how far you've gone, but also over a period of time to be able to say what gains that community has been able to make. So through a one-stop shop approach, health, nutrition, protection, integrated program, joint programming, reporting, community leadership, but also making sure that interventions actually capitalize on an area-based coordination model. So whatever coordination structures exist at community level are empowered. Local organizations are empowered to be able to deliver. Why local organizations? In terms of creating these spaces at community level where you have ECD interventions being implemented, you would only be sustainable if you are able to rely on the efforts of those persons in that community who probably might have been trained on thematic areas, who get to understand this and who continue to even deliver. And maybe the private sector, very, very important, because in terms of ECD, although costly, it's one of the areas that actually get to deliver these services. So in terms of this, one word I'd like to use is the nexus. So would be very difficult to implement ECD services without thinking of a nexus. And equally, will not be possible to implement ECD services without thinking of integration and cross-sectional action. How do you ensure that activities are well coordinated? How do you ensure that each and every sector involved in the nurturing framework is doing what they're supposed to do? And how do you ensure that individuals or children are being met with a maximum number of interventions? And this would only be possible if you're able to define packages. It would only be possible if you're able to define a joint work plan. It would only be possible if you're able to build on local existing capacities, and would only be able if you're able to draw from the strengths of local presence in the community. Now, what could be some of the barriers which we usually face as emergency actors in the field of ECD when it comes to the response? The first, I mentioned it already, it could be some misunderstanding, some misplacement in terms of priorities at the national level. If in some countries you need clear guidance to be able to implement certain activities of ECD, it's very clear you would need some guidance from ministry, especially if these are community activities. I will just build a little from a paper which I read recently about the desire to push for more implementation of ECD activities in low bandwidth crisis. So in such bandwidth, you need to be able to get the government, the leadership to be able to prioritize those kind of interventions. Otherwise, you would always find, I will use the examples of maybe adequate nutrition. Who gets to fortify the food staples? It's national program. Who gets to support with HIV testing and prevention of PMTCT? Of course, emergency actors, but you rely on the system that exists. If you want to talk about social services, if you want to talk about cash or in-kind transfers, social insurance, if you want to talk about issues relating to air pollution. So there are some of the elements of the nurturing framework that actually fall beyond the scope of emergency response, but that need the contribution of governments and the leadership of governments. Some of them are quite very open, allowing certain things to happen, but some of them are quite protective. So you can only build this if you also get them really involved. However, that notwithstanding, there are entry points which emergency actors can always take the bandwidth and start doing something and showing that it's producing results, because most of these activities already fall in line with some of the activities that the different sectors are doing, but not really talking to themselves. So beyond priority setting, it's important that with the local authorities, at the national level, and also with the humanitarian coordination, we should be able to put ECD on top of the agenda. We know in the world of today, you have many challenges. You have climate change, you have COVID-19, you have armed conflict, you have economic hardship, you have increased, there are other many reasons of displacement. So how do you get to let that politician or that leader in that position understand that ECD should be on top of issues besides the other things that they're dealing with? So continuous advocacy, humanitarian country team, cluster lead agency advocacy stays very, very relevant. Now, with respect to ECD, some interventions are very costly in terms of setting them up. But once you do set them up already, they can get running. So in terms of advocacy, again, it's always very relevant that we think of interventions that are cost effective, that also could be implemented over a very short period of time, but building on whatever exists and the strengths of the community, because the communities, when they get to contribute, it makes a lot of things very easy. They can produce the land you need for the safe space, for instance. If you have the private sector that can produce, and maybe basic services, maybe at commune level, where you have maybe the mayor deciding to provide water for a mobile creche, or maybe a static facility where they would decide to make certain contributions, it only makes it easy to be able to implement those activities. One of the challenges that in emergencies we could face when it comes to implementation would be the cultural divide. When we move across countries, you find people of different DNAs, people who see things differently, cultures that allow certain things and maybe deny others. Some are good, depending on how you see it, but maybe to them, there's need for more convincing. So in terms of, maybe I'll use the example of responsive caregiving. I'll use the example of engaging more with fathers and caregivers in terms of what they decide for their children. If you find yourself in that kind of context, you need to be able to develop content that's relevant and to be able to approach the community in a specific way. And it takes time. So you need some patience, but there are other activities that you can engage in and you can build on that. And once you show evidence, it becomes possible. One other challenge which I would like to mention, especially in the past 2-3 years, has been that of the COVID-19. During the COVID-19 pandemic, there were initiatives in Cameroon, for instance, to be able to reach children who were at home with courses online or over the air. However, given the geography of the country, the content needed to be adjusted to be suitable for each of the different populations in the country. So in line with this, it puts in more energy to either to read through scripts, do more adjusting, and to be able to roll this out after getting the consent. And all this, it only takes time. It takes more resources to be able to address. And in terms of challenge, one of the final challenges would be how to articulate what is defined as life-saving in the emergency response. Most emergency responses are defined donors. We want to put the money where we know we are going to save a life. So we have to be able to tell the humanitarian coordinator that by making sure that this child is screened for malnutrition, their life is being saved. And not only being saved, but there are gains later on beyond that. Some of the interventions of ECD might not be overt, but we have to keep looking for ways of convincing them to know the added value of human capital formation for the ultimate years. So summarily, Linda, I'm going to stop there, but I think there might be some questions which I would be able to address if they come. Thank you very much, and over.
Many thanks, Pen. You've covered a huge amount of ground. And I think a couple of points that you've made. I mean, your statement that, you know, a lot already has been done around nurturing care for children, early childhood development, but we're not using the ECD language in our day-to-day work across many of our clusters, and for sure in health. So it begs the question, do we really sufficiently know what is currently being done and the extent of gaps? And as we all know, the HRPs are high-level collective documents which are increasingly lack specificity. So again, looking at what we're all doing on a day-to-day operational level is important. I think you highlighted a number of the opportunities for existing openings, both in the approach that the clusters take to both assessment, planning, strategic planning of the response, the defining what a package of interventions looks like. And increasingly, that is a collaborative process with other clusters. I know for sure health, WASH, nutrition, food security and protection, all engaged to a varying degree in intersectoral approaches, and actually work that is being promoted, but again, perhaps not using the ECD language, but certainly will be providing guidance on how to come together more efficiently and effectively to share the necessary information and join and plan and implement jointly. Again, you mentioned the need for standards, joint packages, standards, indicators. This is around familiarity. How familiar are people with the current standards? I mean, Ron shared some clear standards, as did Aisha. So there's an issue here about familiarity in existing policy and guidance and how it can be implemented. Your points about what's possible in acute crises, what is considered life-saving, a question that we're being increasingly challenged. As you know, the donors are pushing us to be ever more define the boundaries of what is humanitarian versus what is not. And if what is not, then that's going to be picked up by the health system. And throughout all the presentations and your comments, it was very clear on the need to have both informed and supported health workers, both within the system itself and at community level, whether those are government employed or employed by NGOs and others. And I liked your reference as well to the need to be for local leadership and really bringing response down to district and community level. And again, changes taking place in humanitarian and health coordination around that. So there's multiple opportunities and entry points here, but I think it's quite clear, and the reason we're having these conversations is that while the opportunities are there, we're not necessarily jointly identifying them and again working to the same standards and using the same language around what you're doing. And what I want to do, I mean, we've extended by a few moments just to give a bit of space so everybody has the time to speak. I just want to reach out. I see some other Health Cluster colleagues have joined, and I just want to give any of them an opportunity to maybe share from their perspective to what extent they feel early childhood development and the nurturing care framework is being actively promoted within not only the health cluster, but also within the intersectoral dialogue that is already taking place in your settings. So I don't know if anybody's willing to put their hand up. There's no right and wrong answer. This is very much about just sharing perspectives. So anybody willing to take the plunge? Oh, incredibly shy, which is very unusual. Okay, so we've got Erna from Somalia, where there is intersectoral programming going on. But again, ECD not actively on the agenda. And again, I think this is this thing about language that we're using to promote initiatives versus activities that are actually happening. So these are things that will be explored in due course. Any other colleagues online? Okay, seeing colleagues online, but no hands going up. So Pen, can I just ask one, if there was something that you wanted we have the opportunity now, with support of USAID BHA and our engagement with UNICEF colleagues and other partners involved, NGO partners involved in ECD, we have the opportunity now to advance this initiative, and these webinars are the initial conversations around this. From your perspective, what would you want to see to be the real first changes that you would like to see from a health cluster coordinator perspective at country level? What would be most enabling for you to advance this agenda at country level with your health cluster partners and the other sectors that you're working with? Over to you. I'm sorry to put you on the spot. Ben, can you hear me?
Yes, I can hear you. Yes, Linda, thank you very much. Very nice question. I think I'm going to be very greedy and I'm going to say two things. Yes, with such funding, I think raising advocacy at very, very strategic level would put many people and would put this thing on the spotlight. And this is where you want the leaders within the government to be able to position themselves and say something based on an analysis of what's happening at country level on this issue. This is the first point. The second point I would advocate for with that kind of funding would be to be able to have an analysis that brings together, looks at what's happening in the different sectors, highlights, but also gets to propose kind of interventions. Of course, we know a lot is happening already, but you want them to be able to take place together. So defining this package of activities in an adapted way, because what what would happen, what maybe in Ukraine might not be very, very suitable in Cameroon, might not be suitable in Ethiopia that way. So for me, I think this would be the priority, but of course it would mean that every cluster, every sector would need to come together for this kind of discussion, and then you would have more input into it. Thank you very much.
Many thanks, Pen. So clear asks there. So a request for strategic advocacy, so much greater visibility on the issue, both only within government itself, but also across our respective agencies and clusters. And then you see a better understanding as what is actually going on just now. We obviously have some examples from colleagues who presented last week and this week, and certainly the Global Health Cluster will be undertaking a survey with colleagues in the not too distant future to explore what's happening across our 31 clusters and the interface with other sectors. So I'm just seeing a hand up from Dr. Alu from DRC. Floor is open to you, Alu, for comment or question.
Ok, je vais parler en français. Bonjour à tous. Comme on a des traducteurs, pour être très clair, je vais parler en français. Merci à l'équipe de nous avoir donné cette opportunité de parler sur cette thématique très, très importante. Spécifiquement en RDC, oui, ça fait partie de nos priorités. On veut vraiment pousser cet agenda une vision multisectorielle et aussi au sein même de la santé, une vision, je dirais, nexus. Le développement de la petite enfance est une problématique en tant que coordonnateur du cluster santé où on travaille avec les partenaires humanitaires. Nous pouvons pousser cet agenda, d'abord en faisant la promotion à notre niveau, en intégrant cette dimension dans toutes nos évaluations de besoins, comme le prédécesseur a dit, et aussi au niveau de notre planification HNO, de mettre des indicateurs assez clairs par rapport à cela. En ce moment, ça va refléter sur notre réponse humanitaire. Mais ce qui est plus important, c'est vraiment aller ensemble avec les autorités, donc avoir la même priorité. C'est une priorité ici en RDC. Donc, l'idée, c'est vraiment à tous les niveaux, au niveau central, au niveau opérationnel, essayer de faire des co-créations, des co-planifications avec les autorités d'abord nationales, les autorités au niveau opérationnel et en ce moment faire aligner partenaire sur ces priorités déjà définies entre le cluster santé et les autorités. Moi, je pense que c'est cela une voie assez claire et facile pour pousser cet agenda. Aussi, on parle beaucoup de nexus en RDC, notamment dans nos zones à prédilection humanitaire. On a aussi la chance d'avoir des partenaires de développement et on sait que le développement de la petite avance est aussi la priorité. Donc, du coup, pousser cet agenda du nexus, triple nexus, nexus dans le domaine de la santé également, pourra faire progresser cet agenda. Voilà, donc du coup, la vision multisectorielle, surtout le secteur éducation, est une composante très, très importante de cet agenda. C'est vraiment important et aussi la nutrition. Donc, du coup, travailler étroitement comme on le fait, mais en mettant clairement des indicateurs et des résultats bien formulés par rapport à cet agenda. Voilà, c'est ce que je pourrais ajouter à ce niveau. Merci.
Merci, Alu. Thank you for your intervention. Again, clear reference to the need for engagement and sort of nexus, working clearly with both humanitarian and across development actors, the need for clear indicators on tracking what we are doing. So, colleagues, I'm very aware of time because we've overrun, and thank you for those who've stayed online. I'm just going to ask my colleague Andrea if there are any questions in the box. I think there is certainly one for Aisha, if that's...
Yes, indeed. We did have colleagues post in the Q&A section. We have 3 questions in total. And the first one was directed specifically to Aisha. And the question is, are there any examples of ECD assessments and counseling integrated into pre-existing IMCI or IMNCI programs? So Aisha, I'm not sure if you're still able to be online with us, but over to you.
Yes, hello, thank you so much. Thank you for the question as well, because this allows me to put in a plug. If you haven't had a chance, it's worthwhile listening to webinar 2 if you missed it. Because in webinar 2, a couple of our colleagues, particularly the colleague in Syria and a colleague in Ethiopia, gave examples of ECD interventions in health response, specifically in health responses, and particularly in IMNCI. And our colleague in Syria, she told about the whole process around also deciding it and what the pros and cons they went through were, and what the barriers and the challenges, and then how they overcame it and what they did and their evaluation of it. And in Ethiopia, they describe, they don't use the term IMCI or IMNCI, but I'm aware that the Ethiopian government is using specifically an IMNCI approach to healthcare for children and for pregnant women and for mothers. So they were working within the government system. So therefore, even though it's not mentioned in his presentation, it is effectively ECD and IMNCI. And I think, though, there are many examples, and maybe, and I asked Linda and the health cluster coordinators as well, and I think also I should ask our nutrition and protection colleagues if it's worthwhile to collect examples, short case studies with some materials that were used, particularly because, and I'm not the expert in this, but I think there will be colleagues at WHO who are, in terms of recommending which developmental milestone tool, screening tool to use. There are very many out there. So there will be recommended tools, different ones you'll see from our presentations that are different examples, or people were using different tools. And there's nothing, I wouldn't say, as a pediatrician, I wouldn't say there's anything wrong with that as long as the tool is validated. However, to avoid confusion, it's probably, and to really kind of standardize what we're doing and measure it, as Penn had mentioned, because I think measuring is really important to be able to A, hold ourselves accountable, are we doing it, but B, and perhaps more importantly, or equally importantly, is what effect are we having? So maybe what we should do is start to gather some short case examples, sort of collect them and keep them together in one place, as a resource for people who are interested to do this and to understand how they can do it in their own setting. Over.
Many thanks, Aisha, and yeah, very good examples. So or ideas. So we'll follow up on that. Andrea, I'm just going to reach out again. Any other final questions before we?
Yes, please. So the next two questions are around wet nursing. So the long version of the question is for infants and young children. Breastfeeding, skin-to-skin contact, and mother-child proximity is the foundation of health, nutrition, and protection. When mothers are absent, deceased, ill, or separated, other caregivers need to step in to fill that role. For nutrition, that entails wet nursing. UNICEF is currently working on developing wet nursing guidance. How is wet nursing being integrated into ECD and nurturing care? And the second question is very similar to coming to the same point around orphan children and wet nursing, and was directed to Dr. Amir. Over.
Thanks.
Can you hear me? Okay, go ahead, sorry.
No, over to you, Amir. The floor is yours.
No, and there is a national standard operating procedures in Lebanon on infant and young child feeding, which includes, it's quite comprehensive, and it includes multiple components in support of breastfeeding and promotion and protection of breastfeeding. And when it comes to the chapter related to the non-breastfed children, the wet nursing has been a practice in the country, but there is not yet a very systematic approach towards this. However, there is some interest by the Ministry of Health and some of the engaged hospitals as part of the baby-friendly hospital initiatives, who are now showing some interest to further develop potential pilot or model programs on breast milk banks in the country. Perhaps in a few months, I would have more updates to share on this, but this is so far where we are in terms of wet nursing. I don't know if that answers the questions. Over.
Many thanks, Amir. Any other last question, Andrea?
Nothing else in the Q&A. Thank you.
Okay, colleagues, so we've gone slightly over time, so I appreciate many of you staying online. As you can see, this is it's clearly a topic of interest and one of high importance, many multiple facets, which again, I think while there's common understanding and common standards in many areas, whether there's a common understanding across all sectors, and more importantly, whether we're leveraging the opportunities that we have between us to really advance the agenda is clearly something we need to explore further. So these three webinars have kind of set the scene for us and raised important questions, and more importantly, brought us together to continue the dialogue on this initiative, both through our agencies, clusters, and other respective entities. As I said, the Global Health Cluster will be in fairly short time launching a survey to explore very much the situation within health cluster response programming, and looking at what we're doing ourselves, but also how we're integrating with other sectors, at least engaging with other sectors. Once we have those results, then certainly we would share them, and that may even inform webinar 4, but that will be in the new year. So in the meantime, I'd like to thank all our speakers very much indeed, and for all of you for taking the time out to listen. As was stated at the beginning, we will share both the recording and the slide decks from this webinar. And please do keep in touch with us all through your respective focal points, and we look forward to maintaining your interest and for future engagement as we further this agenda. Thank you all, and have a good rest of your day.